Namaste, hello, and good evening, everyone. Welcome to the third and final day of the MeHeLP Dissemination Conference 2021 Kerala segment.
Namaste, good afternoon, good evening, or good morning, wherever you are. Welcome to the third day of the Kerala Mental Health Literacy Dissemination Conference. And we had an excellent 2 days where we had the opportunity to debate, discuss issues surrounding mental health literacy, culturally appropriate mental health literacy, with lived experts, international and national and international academics and researchers, and theater makers and film artists and actors. So it was a very enjoyable and enlightening experience for the last 2 days. We come to the final day of the Kerala Mental Health Dissemination Conference, where we discuss how we can actually shape a policy based on our findings and also with expertise knowledge. So very, very warm welcome to you on the final day. Do make use of our lobby and the resources there, and also make use of the question and answer panel, answer tab on the right-hand side of your screen, and do raise questions in relation to the sessions or any other information that you may actually have. We also have a poll, and I think it's important that you may also wish to attempt the poll in relation to mental health policies. We have a great day, a great jam-packed conversations and discussions organized for you today with international and national speakers. So first of all, before we start going to the main session, we have an address by the Honorary Health Minister from Kerala, Srimati Veena George, and we are going to actually play a short video clip that we have received from the Honorable Minister.
എല്ലാവർക്കും നമസ്കാരം. ബഹുമാന്യനായ ശ്രീ Raghavan, ഡോക്ടർ ചിത്ര വെങ്കടേശ്വരൻ, ഈ കോൺഫറൻസിൽ സംബന്ധിക്കുന്ന ഏറ്റവും ബഹുമാന്യരായ ഏവരുമേ. First of all, I would like to thank you for inviting me to Kerala Mental Health Literacy Project Dissemination Conference. ഈ ഒരു കോൺഫറൻസ് ഏറ്റവും പ്രധാനപ്പെട്ട ഒരു കോൺഫറൻസ് ആയിട്ട് കാണുകയാണ്. ശരീരത്തിന് ഒരു അസുഖം വന്നാൽ അത് തിരിച്ചറിയുന്നതിനും ശരീരത്തിൻ്റെ നോവുകളും പ്രയാസങ്ങളും അത് മാറ്റുന്നതിനു വേണ്ടി ഡോക്ടറുടെ സഹായം തേടുന്നതിനും നമ്മളെല്ലാവരും ശ്രമിക്കാറുണ്ട്. പക്ഷെ ശാരീരിക ആരോഗ്യത്തിനൊപ്പം തന്നെ മനസ്സിൻ്റെ ആരോഗ്യവും ഉറപ്പുവരുത്തേണ്ടത് അനിവാര്യമാണ്. അസ്വസ്ഥതകളും വേദനകളും ശരീരത്തിൻ്റെ രോഗങ്ങളും തിരിച്ചറിയുന്നതിനും യഥാസമയം ചികിത്സ തേടുന്നതിനും നമ്മൾ ശ്രദ്ധിക്കാറുണ്ട്. മനസ്സിൻ്റെ ആരോഗ്യ പ്രശ്നങ്ങളും രോഗലക്ഷണങ്ങളും രോഗാവസ്ഥകളും തിരിച്ചറിയുന്നതിനും ശാസ്ത്രീയമായ ചികിത്സ തേടുന്നതിനും ഭൂരിപക്ഷം ആളുകൾക്കും കഴിയുന്നില്ല എന്നുള്ളത് ഒരു യാഥാർത്ഥ്യമാണ്. എന്തുകൊണ്ടാണിത് സംഭവിക്കുന്നത് എന്നുള്ളത് നമ്മൾ പരിശോധിക്കേണ്ടതാണ്. മാനസിക ആരോഗ്യം സംബന്ധിച്ചിട്ടുള്ള കൃത്യമായിട്ടുള്ള ഒരു അവബോധം നമ്മുടെ ആളുകൾക്ക്, ഭൂരിപക്ഷം ആളുകൾക്കും ഇല്ല എന്നുള്ളത് ഒരു പ്രധാന കാരണമായി ചൂണ്ടിക്കാണിക്കപ്പെടുന്നുണ്ട്. ഇത് സത്യമാണ്. അതോടൊപ്പം തന്നെ മാനസികാരോഗ്യം സംബന്ധിച്ചിട്ടുള്ള പല തെറ്റിദ്ധാരണകളും നമ്മുടെ ഇടയിൽ നിലനിൽക്കുന്നുണ്ട്. ഇവിടെയാണ് മെൻ്റൽ ഹെൽത്ത് ലിറ്ററസിയുടെ പ്രാധാന്യം, മാനസിക ആരോഗ്യ സാക്ഷരതയുടെ പ്രാധാന്യം ഉണ്ടാകുന്നത്. മാനസികാരോഗ്യ പ്രശ്നങ്ങൾ ഉള്ളവരിൽ വളരെ കുറച്ച് ആളുകൾക്ക് മാത്രമേ ശാസ്ത്രീയമായിട്ടുള്ള ചികിത്സ ലഭിക്കാറുള്ളൂ. അല്ലെങ്കിൽ ശാസ്ത്രീയമായിട്ടുള്ള ചികിത്സ തേടി ചെല്ലുന്നവരുടെ അല്ലെങ്കിൽ അവരെ എത്തിക്കുന്നവരുടെ എണ്ണം വളരെ കുറവാണ്. അപ്പോൾ മാനസികാരോഗ്യ സാക്ഷരതയുടെ അഭാവം കൃത്യമായി ചികിത്സ തേടുന്നതിന് വിലങ്ങുതടിയായി മാറാറുണ്ട്. കൂടുതൽ ആളുകളിലേക്ക് മാനസികാരോഗ്യ സേവനങ്ങൾ എത്തുന്നുണ്ട് എന്ന് ഉറപ്പുവരുത്തേണ്ടത് ഒരു അനിവാര്യതയാണ്. അതുകൊണ്ടാണ് സംസ്ഥാന സർക്കാർ നമ്മുടെ ശാരീരിക ആരോഗ്യത്തിനൊപ്പം തന്നെ മെൻ്റൽ ഹെൽത്തിനും ഈക്വലായിട്ടുള്ള, തുല്യമായിട്ടുള്ള ഒരു പ്രാധാന്യം കൊടുത്തുകൊണ്ട് തന്നെ മുന്നോട്ട് പോകുന്നതിന് ആലോചിക്കുന്നത്. അതിനായി വിവിധ തരത്തിലുള്ള പരിപാടികൾ നമ്മൾ സർക്കാർ തലത്തിൽ ആലോചിക്കുന്നുണ്ട്. നമുക്ക് പ്രാഥമികാരോഗ്യ തലം വരെ മെൻ്റൽ ഹെൽത്ത് സപ്പോർട്ട് കിട്ടുന്നതിന് വേണ്ടിയിട്ടുള്ള ഇടപെടലുകൾ ആവിഷ്കരിക്കണം എന്നുള്ളതാണ് ആലോചിക്കുന്നത്. അതിൽ ഏറ്റവും പ്രധാനപ്പെട്ടത് ഇങ്ങനെയുള്ള സൗകര്യങ്ങൾ നമുക്ക് സർക്കാർ തലത്തിൽ അല്ലെങ്കിൽ പ്രൈവറ്റ് മേഖലയിൽ ഉണ്ടാകുമ്പോഴും അത് ആ സഹായങ്ങൾ അല്ലെങ്കിൽ ആ സേവനങ്ങളെ ഉപയോഗിക്കുന്നതിന് ഉതകുന്ന രീതിയിലുള്ള മാനസികാരോഗ്യ സാക്ഷരത ഉണ്ടാകേണ്ടത് വളരെ പ്രധാനപ്പെട്ട ഒരു കാര്യമാണ്. അതുകൊണ്ട് തന്നെയാണ് ഈ കേരള മെൻ്റൽ ഹെൽത്ത് ലിറ്ററസി പ്രോജക്റ്റ് ഡിസെമിനേഷൻ കോൺഫറൻസ് വളരെ പ്രധാനപ്പെട്ടതായി ഞാൻ കണക്കാക്കുന്നത്. ഈ ഒരു മീറ്റിങ്ങിലേക്ക് എന്നെ ക്ഷണിച്ചതിൽ ഞാൻ നന്ദി അറിയിക്കുന്നു. ഈ ഒരു സാഹചര്യത്തിൽ പ്രത്യേകിച്ച് നമ്മുടെ ന്യൂനമർദ്ദങ്ങളെ തുടർന്നുണ്ടായ അപ്രതീക്ഷിതമായിട്ടുള്ള ശക്തമായ മഴയെ തുടർന്ന് ചുമതലയുള്ള ജില്ലയിലെ പ്രവർത്തനങ്ങളുടെ ഭാഗമായി നിന്നുകൊണ്ട് ഈ ദിവസങ്ങളിൽ അവിടെ തുടരുകയായിരുന്നു. അതുകൊണ്ടാണ് ഈ ഒരു സന്ദേശം എത്തിക്കാൻ അല്പം വൈകിയത്. എന്നെ ക്ഷണിച്ചതിൽ പ്രത്യേകം നന്ദി. പ്രത്യേകിച്ച് ഈ ഒരു പ്രോഗ്രാമിലേക്ക് ശ്രീ രാഘവൻ, അദ്ദേഹം നമ്മുടെ കേരളത്തിൽ ഈ രീതിയിൽ ഒരു അസോസിയേഷനിലൂടെ ഇന്ത്യയിൽ നടത്തുന്ന മെൻ്റൽ ഹെൽത്ത് പ്രോഗ്രാമിൻ്റെ ഭാഗമായി ഈ കോൺഫറൻസ് വളരെ മികച്ച രീതിയിൽ, അതുപോലെ ഡോക്ടർ ചിത്ര വെങ്കിടേശ്വരൻ ഈ പരിപാടിയിലേക്ക് എന്നെ ക്ഷണിച്ചതിൽ നന്ദി അറിയിക്കുന്നു. നല്ല ഒരു ഫ്രൂട്ട്ഫുള്ളായിട്ടുള്ള ഒരു പരിപാടിയായിട്ട് ഇത് മാറട്ടെ എന്ന് ആത്മാർത്ഥമായി ആശംസിക്കുന്നു. നന്ദി, നമസ്കാരം.
Thank you, Honorable Minister for Health in Kerala, for taking the time in these difficult times in Kerala to address our conference and also to share your thoughts on this important event. Thank you very much for highlighting the need for mental health literacy and your kind words and your kind and encouraging words, I must actually say, and hope to actually work with you and the government in relation to promoting mental health literacy in Kerala. Many thanks.
Our first session for the day is about mental health policy and practice. To chair this session, I would like to welcome Dr. Sivakami Muthusamy. Dr. Sivakami is professor in the School of Health System Studies, Tata Institute of Social Sciences, Mumbai. She is also the chairperson of the Center for Health and Social Sciences, one of the 4 centers in School of Health System Studies, Tata Institute of Social Sciences, Mumbai. She is one of the co-investigators of our project. Over to you, ma'am.
Good afternoon, good evening, good morning to all of you who are tuned in to day 3 of our conference. It gives me great pleasure to welcome you all to the session on today's technical session on mental health policy and practice. We are going to get started our day with another stimulating session, which is on the very core issue, which is mental health policy and practice. We have 3 wonderful speakers in this session. If you have attended our last 2 days of the conference, you are already familiar with all the 3 speakers and their wonderful work. They are all engaged in the field of mental health. For all the people who joined today for the first time, you can be rest assured that by end of the session, these 3 amazing speakers are going to leave you with some thought-provoking ideas. Without much delay, I'm going to invite all 3 speakers on the stage: Professor Raghavan, Professor Brown, and Dr. Manoj Kumar on the stage. Thank you, all the 3 gentlemen, to be with me on the stage. And it's absolutely an honor and absolutely a delightful moment to be with you 3 for the next 1 hour. Before I introduce and invite the speakers, the first 2 speakers, Professor Raghavan and Professor Brown, I have 2 housekeeping announcements to make. And everybody, on your right-hand side, you will see a button which says chat. Please do engage with us on the chat, whatever you want to communicate with us about the session and about the conference. And you will also see another button, which is the Q&A. And please do post your questions for the session to the speakers. If you can post pointed towards in the Q&A, we will be able to pick up that and answer your questions along the sessions. And now I will turn to Professor Raghavan and Professor Brown to talk to us about on how can mental health literacy shape mental health policy and practice in Kerala. But before I let them take on the stage, it's my pleasure to introduce both of them. And Professor Raghavan is in the transcultural mental health and well-being. Professor Raghavan is also the principal investigator of MeHeLP project, which is what we are discussing in the last 3 days. Professor Raghu's clinical background is in health policy and nursing with expertise in participatory research and co-production. His research focuses on 4 overarching but interrelated themes which addresses the issues in mental health, disability, and well-being. It's absolutely a delightful moment to have you on the stage, Professor Raghu. And now it's my pleasure to introduce the co-speaker with Professor Raghu is Professor Brown. Professor Brown is Professor of Health Communication at the Montfort University and brings substantive research expertise in health humanities and worked in a number of AHRC funded projects. He is also co-investigator in the MeHeLP project. The core of Professor Brown's work has focused on the interpretation of human experiences across a variety of different disciplines, including healthcare, philosophy, education, and spirituality studies, exploring how this may be understood with a view to improving practice and with regard to theoretical development in social sciences. And now the floor is to you, Professor Raghu and Professor Brown. Take on the stage.
Right. In this session, myself and Brown, we are actually going to explore how can mental health literacy shape mental health policy and practice in Kerala. So with this is a way of how we can share the findings from the project and how we can actually pitch our findings that might be relating to policy and how services could be developed in Kerala in the light of the context of public mental health and the mental health literacy, the culturally appropriate mental health literacy should actually signpost the people in relation to that. So as we discussed on day one, we talked about mental health literacy. What is mental health literacy? And it comprises of 6 components from the Western medical model of psychiatry, but we must also add the 7th dimension to it, the kind of cultural appropriateness and the cultural norms and the cultural heritage that might actually add value to this process. So it is actually the ability to recognize specific disorders or different types of psychological distress or conditions, and knowledge about risk factors and causes, and knowledge about self-help interventions, knowledge about professional help available and how to seek them, attitudes which facilitate recognition, which means exploring or trying to address the kind of stigma around mental health or mental illness, and the knowledge of how to seek mental health information. And to that, we would actually add the 7th dimension of cultural appropriateness and cultural norms and cultural heritage that might actually provide value and meaning to the way we actually look at mental health and well-being. So some of the key findings from our study and that might actually shift or shape the policy for the future in Kerala, that the kind of knowledge of risk factors and causes are influenced by social cultural menu. So I think it's important to try and understand that from the social perspectives and the cultural perspectives, the economic perspectives that might actually underlay here. Because if you're not actually looking at those factors, that we might not be addressing the real issue surrounding mental ill health. Because mental health is not just the absence of symptoms. Mental health is much more than that. And I think it's important that we address that from a collective, a holistic way of actually looking at health and well-being. And people living in rural and tribal Kerala, we found that they associate the causation of mental health problems primarily to God's destiny and supernatural causation. And I think that's that's an important finding in itself, because it is it relates to their own belief systems. And urban areas associate causation to the biomedical model. Maybe there are the education or the literacy levels might actually have played a role here in terms of shifting their attention to the biomedical model. But I'm not here to actually set any judgments in relation to the biomedical model is good or the other causation of destiny model is actually appropriate or anything like that. Because I think tension, all the kind of interviews, the 200 odd interviews that we have actually conducted, and also the kind of theater activities that we have actually done with the communities, and the film engagement that we have actually done with communities, all sort of focus on tension. Much more than depression, tension is a common word. Everybody mentioned about the narratives across all sides and in terms of mental illness. But whether they attributed tension to be part of mental illness or tension on its own that we actually experience on an everyday basis, or whether tension is considered to be a symptomatic issue, is something that we need to further explore in this context. So some of the local concepts of mental illness, depression is a distinction between intense sadness as an illness and everyday sadness as part of that part of life that actually passes, while many of them actually consider it as a mental health condition, which I think it's a finding in itself. How do people see everyday sadness that might be part of life, and how they overcome that and pass through those things and understand what is happiness, etc. So I think it's important to actually see depression and sadness as two different contexts and concepts in relation to well-being. And people often said Vishadam or depression prevents the person from doing his or her routine activities. This is a kind of gender imbalance here in many ways, because most of the people, the wives or spouses, it is actually directed at them that they brood and they don't do any household chores or work because of the fact that they are actually feeling sad or they're feeling depressed. And the terminologies of madness, Vata or Brando, where a person behaves violently, throws things around, physically abuses people, and loses of mind, I think that still is prevalence. But I think whether that is actually a kind of correct understanding of mental ill health is something that needs to be questioned in this context, really. Even from the model of Western psychiatry, that is not actually kind of very much appropriate in this context. And compulsive behavior in the Malabar community of Ponani, this one a very cultural heritage city in northern Malabar, there was actually mention of auswas, of compulsive behavior, often linked to the kind of possession, spirits and possessions. And some service and caregivers in the urban area were able to use appropriate medical terminology to describe their illness, which I have actually alluded to earlier on. And the economic burden, as I mentioned at the very beginning, economic burden is an overarching theme in the rural and tribal areas. And I think it's mainly because of the fact that people often find it very difficult to actually go and seek help with a mental health professional because it actually costs money. And that they are not aware of the existing district mental health programs or the NGO programs that might be around. And whereas in the urban sites and work pressure and restrictive societal norms are actually described as well as kind of as a burden issue in this context. So next, round.
Yes, thank you very much, Raghu, and thank you also very much to Professor Sivakami for that very generous introduction. It's a great pleasure to be on a virtual platform with you again. Now, the reason we're going through all this is because it's important to understand the kind of cultural background, the kind of cultural context in which policy and practice has to work, because it's often a little different from that in which the notion of mental health literacy was developed. Some of you are aware it was Jorm and his colleagues in Australia, I think, who originally proposed the notion of mental health literacy. So although Australia's in the south, we often see these concepts as coming from the global north, from the English-speaking world, from Western Europe and North America. To what extent will they work in a country like India or in any other low to middle income country? Now, one of the things we also noticed and came out quite strongly from the interviews was what we've referred to as pluralism. People appeared to be aware of and be literate within a variety of different healing regimes. As we will see in a moment, some of these draw from the spiritual heritage and traditional healing practices, but equally, as Raghu has mentioned, some people, perhaps particularly urban residents, tend to draw upon more modern, more, dare I say it, Western medico-psychotherapeutic models, concepts, terminology to understand distress and disorientation. And that traditional and spiritual approaches were more likely to be endorsed by people in rural areas. But equally, they were not averse to seeing a health professional and taking prescribed medication as well. For people in urban areas, they were perhaps most likely to indicate that they'd be inclined to visit a psychologist or a psychiatrist to modify their lifestyle, to reduce the influence of tension. It's interesting, people talk about tension within India. Here in the UK, where I'm based, people are perhaps more likely to talk about stress. You know, it performs a very similar function in everyday discourse. You know, I'm stressed out, as we always say in the UK. Oh, let's have the next slide, Raghu. Okay. Yes, it's important in understanding the context in Kerala, the context in India, to understand the role that faith or religious healers may play in people's response to distress or disorientation or unacceptable behavior. And especially in rural and tribal sites, these sources of support often emerged as the first line of management. Perhaps people, especially in the area of Elapulli, were apt to consult magic practitioners or perhaps Hindu priests. There were a variety of rituals that people were apt to use, like Haman and Kalam, which involved animal sacrifice, which they believed freed the body from the spirits, which were possessing you in order to make you unhappy or make you behave in a socially unacceptable way. And another thing that came out quite strongly in many of the interviews was the role of religious observance as well, attending the temple, attending the church, prayer, meditation, chanting. And in this respect, religious sites and religious institutions represent an important source of healing. And it also adds meaning and structure to people's days or to people's weeks. There's rituals that you do in the morning and rituals that you do in the evening. And you engage, perhaps, if you're a believer, in these shared activities towards a common purpose that bring people together. And there's rituals like an example we've got on the slide there. I can never pronounce this properly. Palabhishkam, ritual of bathing an idol with milk while chanting a mantra. So there's a variety of rituals that people engage in to promote their healing and recovery, apparently, or to give at least structure and meaning to bizarre or distressing experiences. And, well, some people felt these were very valuable. Others felt that it worsened the cared for person's problems. And in Chotinikara, which is home to a very famous temple that is reputed to cure mental health problems, yes, people were using prayers and temple visits, chanting, meditation, and so on. But it's almost as if they were using that as a way of promoting well-being and peace. And as I mentioned earlier, people were sometimes using a variety of different healing regimes. That is, they were attending the temple, they were chanting, they were participating in services and observances, but they might also be visiting a doctor and taking tablets. That's in the Hindu tradition, but in the Muslim tradition, we also noted that there's a rich heritage of spiritual and traditional healing. For example, rituals to remove jinns or evil spirits from the person or for the person's life. Oh, let's have another slide. Okay, so to sum up some of what I've said already, the family is often a very important source of support, but also a source of negative attitudes and stigma. So, there's some tension in family relationships sometimes. People very widely felt that it was important to hide mental illness because it would affect one's marriage prospects. Nobody would want to marry you if you had a history of madness, that it would affect one's work opportunities, and it would affect one's ability to subsequently have a family of one's own. As I mentioned already, for many people, the role of prayer was especially important in improving well-being, in managing distress or distressing symptoms, and was widely seen as an aid in recovery. Oh, let's have another slide, please. Okay, so we've already said that there are a variety of healing regimes and ideas and beliefs that people draw upon, including more modern medico-psychotherapeutic ones, but also a whole variety of spiritual and traditional heritages which people make use of to address and attempt to achieve recovery. So, on the basis of our experience in this project, we would argue for some rapprochement between medical, spiritual, and traditional ways of thinking about unhappiness and disorientation. And maybe there's a way of bringing together the best from all these traditions, all these different healing regimes, because people are adopting a kind of pick and mix approach already. So I think to encourage better mental health treatment and provision, better mental health literacy, this needs to be acknowledged as a starting point. Now, the trouble is if you take the notion of mental health literacy as Jorm and his colleagues originally proposed it, it tends to predispose a very medico-psychotherapeutic way of looking at distress and disorientation. Anything else is mistaken beliefs, it's old-fashioned superstition and stigma. Whereas once you look at what people do and what they believe and how they structure their lives, actually it's a bit more complicated than that. And I'm only a visitor to India, but one of the things I noticed is that there's a very proud and long-standing tradition of legend and literature, of spirituality, of healing practices, which many people in India are justifiably proud of. I think just to tell people, oh, that's just old-fashioned superstition, get rid of it, would be very insensitive. Oh, let's have another slide, shall we? Sorry, this is something I've already anticipated in my comments on the last slide, but yes, it's just the assumption underlying many mental health literacy campaigns that a medico-psychotherapeutic way of understanding distress is always the best one. And that, as I've alluded to, some of these practices that we've described are important because they offer a sense of meaning, a sense of purpose. They provide structure to people's days or structure to people's weeks because there are rituals that you perform at particular times of day in conjunction with other people. They help in that way build meaningful social bonds. And also, if we find people unwilling to talk about mental ill health, well, often this is put down to stigma, and stigma is a terrible thing, and we should try and eliminate stigma. But don't forget, people might quite legitimately want a bit of privacy about their personal affairs. Even in the most collective communitarian societies, there's a notion of privacy, and perhaps being part of the world of adulthood, being able to manage your own affairs, is to be able to have a little bit of privacy for oneself. So if people aren't talking, that's not always a bad thing. Okay, let's have another slide, shall we? And at this point, whoops-a-daisy, there we go. Maybe we could bring Raghu back into the conversation again, because these are some possible policy directions which Raghu came up with. So would you like to comment on some of these, Raghu?
Yeah, thank you. Thank you, Brown. So from our findings, I think it's important that that the cultural, social notion of mental health literacies is actually taken into account, and how they could be part and parcel of public mental health programs. Because as such, we don't actually have public mental health programs. We have public health programs. But how about integrating the public mental health programs into the existing public health programs? So integrating the public mental health programs to grassroots organizations such as Kudumbashree, NGOs, district mental health programs, etc., would be the key in terms of trying to integrate the existing practice, trying to feed into the existing practices in terms of how people's knowledge and practice and awareness actually shape the service development and policies. And mental health literacy, well-being, and resilience programs should be part of the schools and colleges and universities. And I know both the state government and the Union government of India are actually currently thinking about that. But I think it's not just imparting the Western model of psychiatry in this context, but how can we effectively make mental health champions in schools and colleges and universities? How can we actually make the future citizens of India mentally healthy? And I think that should be where we should be pitching in terms of the mental health literacy concept. Not an endless model, but a health and well-being and resilience model is what we need. And mental health literacy program, it should be in terms of the professional education, because the professional education should be able to, the professionals need to understand mental health literacy in the first instance, rather than looking at an illness model. I think we also need to be understanding the wellness model too. It is absolutely vital that we should not actually go in the route of medicalizing mental health. Please, let's refrain from that. And let's look at mental health in its context, in the social, cultural context, and not to actually have a pharmaceutical company governing everything, every emotion that we have, and not every pill that we need to take for controlling our emotions. So it is important that the cultural, social context and cultural heritage plays a major role in promoting these. And mental health literacy programs to cultural organizations and digital media in the current context is extremely important, so that it actually reaches the far crowd in villages, towns, and cities of Kerala and the rest of India too. And a major thing, I think this might be more controversial, but we put in the mandatory training for print, visual, digital media workforce. Because I think it's important that they have to provide the right kind of information, right knowledge, and right kind of practices, rather than stigmatizing and also providing the wrong kind of information about mental health and mental illness. And I think it's important that we collectively think together and work together in this context through public engagement, through some of the creative practices that we have actually used. So I would see the policy kind of developing over the next 5 to 10 years in relation to community engagement, and some of the work that Manoj and Chitra Venkateshwaran do in terms of NGOs, and also some of the other NGOs in India as well. So I think it's important to try and tag on with those NGOs or organizations who are actually working socially and economically and culturally, and shaping up the policy and future direction of how we create a mentally healthy Kerala for the future. Thank you.
Thank you, Professor Raghu and Professor Brown, for highlighting the importance of psychiatric pluralism and traditional healing practices. I think understanding these very important in a diverse country like India. I mean, Kerala is not different. And also, I deeply appreciated you bringing home the importance of mental health literacy in terms of shaping the policy. And also the highlighting the importance of bringing the different stakeholders, such as medical, psychotherapists, and spiritual healers together to get the people better and mentally well. And I finally appreciated actually highlighting the need for public mental health program. I think we have a very different mental health program. I think what we need to focus in the country is the public mental health program. So thank you so much. And before I turn to Dr. Manoj Kumar, again, I'm going to do a housekeeping announcement. Please do engage with us in the chat box. You can actually post what you thought about the speakers and the findings that they have highlighted. And if you have a burning question, please do post it in the Q&A. And this will help us to take up your questions and answer as we proceed with the next speaker. Thank you so much. And I'm going to actually now turn to Dr. Manoj Kumar. Dr. Manoj Kumar is from Mental Health Action Trust, Kerala. Dr. Manoj Kumar is the founder and director of MeHeLP. He has won numerous awards with more than 15 years of service with the National Health Service in the UK. He returned to India and founded MeHeLP. MeHeLP is a charitable trust that offers free, compassionate, continuity-based, volunteer-led and cost-effective mental health care system to cater to those from the most economically backward groups of society. And he's going to talk to us on inclusive community services for urban, rural, and tribal Kerala. Dr. Manoj, the stage is for you.
Thank you very much, Professor Sivakami, for the kind words of introduction. And once again, thank you to the organizers for allowing me to on the stage for this very important session of the third day of the Kerala conference. So, good evening to all, good afternoon and good evening to all assembled virtually here. What I want to talk about today is really, I mean, Raghu and Brown have very eloquently pointed towards the policy implications of mental health literacy and MeHeLP program. And I would like to focus on the service implications of mental health literacy and current program. Our conference tagline says mental health literacy is the need of the hour, and absolutely nobody attending will question that. So, you know, it is very clear that increasing mental health literacy is a good thing. But behind that agreement are, I feel, several vexatious questions. For example, when we say that increasing mental health literacy is required, is it possible? Can we really change the baseline mental health literacy of a population? Can we sustain that change? There is some evidence that there is a short-term increase in knowledge. Nobody knows whether that is sustained. Okay, let us take it that the knowledge component of the mental health literacy, the definition that Professor Raghu showed, had 6 components, out of which 5 were about knowledge and 1 was about attitude. Yes, we know that knowledge may be increased at least in the short term, but what about attitudes? Does this knowledge increase translate to behavioral changes, especially at a deeper level? We know that only legislative action makes us change our behavior. For example, a two-wheeler rider wearing a helmet. The government can force us to wear a helmet, but nobody can force us to put the strap on. So people wear their helmets without the strap off, or only when they spot a policeman. So we do know that in health, behavioral changes are extremely difficult to engineer. And what about the interventions themselves? Do mental health literacy interventions work? If so, how do we measure that? How do we measure change? And how much do we spend on increasing mental health literacy so that it remains cost effective? All of these lead to the most important question, in my opinion, which is that what is required apart from enhancing mental health literacy? Because the ultimate goal that we are hoping to achieve by increasing mental health literacy is, as various speakers have pointed out, to improve the mental health of the population as a whole, mental health and well-being. Treatment of mental disorders is an important aspect of that. And we know from the last 2 days of conference that the treatment gap continues to be exceedingly high. So if our goal is to enhance those aspects, mostly at least improving the treatment rate of people with more severe problems, that should be the ultimate goal, so that people come forward and seek treatment with a reduction of stigma. If we agree on that, as one of the speakers yesterday pointed out, there is the Kerala paradox, which is that one of the Kerala paradoxes, as we all know, which is that in mental health, despite increased input of resources, every district has functioning district mental health program. The number of psychiatrists have increased significantly. Both private and the governmental sectors have ever more increasing resources. But these are all in the medical model, which Raghu has cautioned that is not the only model. And therefore, the treatment gap remains as huge as ever. What are these barriers to access care? We all know that the services continue to be standalone services mostly. They're centralized and urban based, which means that people, especially the poorer sections, have to travel to the cities, spending a lot of money and losing money also from loss of employment, because people have to be accompanied in their journey to mental health centers. Treatment is expensive, mostly in the private sector, but we must also remember that there are multiple systemic issues. We're still having a system which is focused on acute care. There is no system for regular follow-up care. And as the chairperson pointed out, the lack of a public health system for mental health. State refusing to take the responsibility for a public health model which would focus on prevention of relapses and good mental health are all systemic issues. So I would argue that despite resources increasing, these systemic issues are conspiring to prevent people from reaching out to the good quality care which may exist. Why is it so? And that probably is also an opportunity to look at the systems theory from a complexity model. For far too long, most of the systems, whether in the governmental sector or in the private sector, have borrowed from the models, the linear models from the industrial era. For example, the body or even a system is seen as a machine whereby all the different parts work together. And if one part is damaged, then that part could be substituted by another part and the machine will continue to work. In the medical model, it is often the military model where the senior doctor is the military commander, and his or her instructions are carried out and healthcare provided in such a fashion. However, we have moved from the industrial era to what we now call the knowledge era. And therefore, these linear models are no longer suitable. And that's where complexity theory comes in. As many of you are familiar with it, systems do not work in a linear fashion. Between the individuals within a subsystem and the interactions between subsystems are complex and dynamic with unpredictable outcomes. And the complexity science says that by understanding the individual parts and their interactions, a more complete understanding of the whole can be achieved. Let me explain. How do we apply this to the mental health? Do we see clients as machines who come to hospitals, get their medications, they go home and are cured? Do we see healthcare systems as linear? Hospitals certainly still function in a linear model, pretty much like a system whereby the ill person goes in and comes out cured at the other end. This cannot be the case as far as community healthcare systems are concerned. These are complex, interacting, dynamic, and flexible. This is because between agents within the agencies, there are complex interactions happening with unpredictable consequences. The interactions between agencies are again complicated, and all this has to exist within the wider ecosystem and also the policies and laws of the land. For example, if suddenly the COVID interferes with our lives and there are lockdowns and so on, the health system grinds to a halt. There are no more outpatient clinics possible, and suddenly the system has ground to a halt. Policies or laws can change, sometimes overnight, and again changes can happen. So currently, as an organization, we are focusing on the tribal populations of Wayanad and in the south near Idiki, and also the fisher communities along the coastal areas. And this has been a very interesting experience. And some of the lessons that we have learned is that, as was pointed out in the earlier presentation, the overriding most important factor is poverty. Culture is important, but it's more complex. Brown pointed out to the plurality angle of it, but very often culture is important only in that it should inform the delivery of care. If you look at the aspects of mental health literacy, the only place where culture comes in and is at loggerheads with popular belief is in the causation. So I feel understanding causality is not important. Supernatural causations are, not that far removed from our so-called understanding about the brain and the, brain systems. I feel that is the only thing which really jars when we are dealing with communities, and it does not seem to be important. As if you might remember, on the first day, Dr. Narayan from Attapadi, where MeHeLP Foundation provides the psychiatric service, pointed out that with a regular system, the treatment gap is significantly reduced. Now, the language is different, the culture is different, the belief systems are different. But in all cultures across the world, there is a recognition of mental illness, and it does not matter what people think causes mental illness. What matters is that there is help with minimum barriers, and access it, and the ability to access it seems to be the only really important aspect, whether services are rural, urban, or in tribal areas. And how do we do it? Very briefly, we are a small team comprising of psychiatrists, psychologists, social workers, and lay mental health workers. And what we do in order to meet the complex demands of community mental health care is that we leverage existing healthcare infrastructure, and by working through a big team of volunteers, we reach out to large number of patients. We have been doing that for nearly 13 years. More than 5,500 people have benefited. At any point in time, there are about 2,500 people. And all this is done in close collaboration with a variety of local partners. And there are 4 key elements to achieving that. So as I said, we need to think differently. We need to recognize that these are complex systems which need to be fine-tuned, and they are dynamic and flexible. And for this to happen, the first key element is that the services should be decentralized. By working through volunteers who are deeply rooted in their own community, many of the barriers, many of the obstacles between the service providers and the clients are overcome by the use of volunteers. The lack of professionals is dealt with by using task sharing as a model, and increasingly technology is playing a more and more important role. So we partner with more than 45 local groups. They're all empowered and autonomous and volunteer based and led, and the volunteers play various roles depending on their their timing and interest. But the most important thing as far as volunteers is concerned is that they need ongoing training, supervision, and support. And the task sharing model also requires a lot of supervision and support, where the emphasis is on training and not on qualifications. But telepsychiatry, or the use of technology, has become more and more important. During the last 2 years, specifically with the COVID enforced restrictions, we have come to rely on video conferencing a lot. Increasingly, use of mobile phones and mobile apps. We have a good database which generates electronic prescriptions, and that incorporates illness management systems also. Round the clock telephone access is there, and there are early warning systems for relapse detection. All this goes to meet the continuously changing and unpredictable needs of people with mental disorders. And that is where the flexibility comes into it. So I end with the following submissions. I feel that attempts to improve mental health literacy, whether we use traditional methods or novel ones, are doomed to fail if it is not matched by changes in mental health service models. So the biggest message is that mental health service delivery models have to change. What the mental health literacy program and the wealth of data that we have got now all point to the same issues again and again, of the difficulty of accessing care, irrespective of what they believe about the causality of mental disorders. Linear models have to be maybe responsible for the treatment gap remaining high, despite the society making apparent progress. So innovations based on understanding the inherent complexity of mental health systems in the current era are required, and I submit that such innovations are possible. Thank you very much.
Thank you, Dr. Manoj, for that illuminating examples and highlighting the need for preventive model for mental health, and urging the policymakers to focus on systemic issues and calling for addressing the social determinants. And I saw you elegantly pointed out poverty needs to be addressed. And also showcasing MHAT effort to include local groups and building their capacity and appealing to change for mental health service care. Thank you so much. And now I have a couple of questions that have come in the Q&A. And one question, I think it's for all three of you. Probably you all can take that up. Do you really think approaching spiritual healers will help the mental health? Who's going to go first?
Shall I?
Yeah, go ahead.
Manoj.
Yeah. I think, personally speaking, I am all for working together with spiritual healers. But having worked all these years in Kerala, there is a real confusion about it. Because the Kerala society has been encouraged to believe in science, for a long time, and people really want to believe that. So when we advocate a close working relationship with traditional healers, the question that we get asked often is, are you not encouraging false beliefs? Are you not encouraging the tradition, the old-fashioned wrong belief systems? But practically speaking, I think the way forward should be to really work together. Occasionally we do that, and then it is very successful.
Thank you. I have another question, Professor Raghu and Professor Brown. The question is for you. Do your professional experience and literacy projects in India indicate that mental health literacy is higher in the UK than India? In that case, what would be the factors in the UK be helpful for that? This is from Sona K.
Brown, yes.
Sorry, I was just unmuting myself there. That's an interesting point. Wherever you go in the world, people have a way of understanding distress, of unusual experiences, of people who might behave in a socially inopportune or unacceptable manner, and why this might be. And of course, in India, you tend to find, maybe more in the UK, people drawing upon spiritual repertoires of understanding to make sense of that. Whereas in the UK, as I mentioned earlier, you often find people talking about stress, adverse experiences. You find people using more, sort of medical model ways of understanding. Now, in the UK, you could say, well, we're very mental health literate because we're, for example, very good at recognizing depression in ourselves and in one another. In fact, in the UK, in 2019, I read in the British Medical Journal, there were over 70 million prescriptions for antidepressants issued in the UK. That's more than there are people. Now, of course, many people are getting repeat prescriptions, but we're very good at recognizing depression in oneself and one another and seeking medical help for it. However, I think a country developing its healthcare services like India or any other LMIC, health leaders would want to think very carefully before deciding that that's a route they want to follow. In a country the size of India, that would amount to of the order of billions of prescriptions for antidepressants. I'm sure the pharmaceutical companies would be delighted, loads of business. Whether that necessarily would lead to an improvement in the stock of human happiness, perhaps is more debatable.
Yeah,
okay, thank you. I have a few last seconds, so quick thoughts.
Sure. One point. I think we should not over-medicalize what is already been existing, medicalization of life, really. I think what is actually important is in the UK, the prescriptions are actually given quite generously. You don't necessarily have to have a mental illness to actually get a prescription. It is actually dished out just like sweets by our practitioners here. So I don't think India should follow that model, is one question. Medication is actually required in certain contexts, and I think a collective approach would be useful. And may I also point to what the earlier question in terms of the spirituality, there's abundant evidence from India itself how psychiatrists and spiritual healers work together from anthropological sources that are in the northern part, in Calcutta and Delhi and many other places. There are good reports as to how they closely work together. Psychiatrists refer to the spiritual healer refers to the psychiatrist. So it is possible, there is ample evidence of that, how the collective model would actually work.
Yeah, thank you, Professor Raghu. Again, highlighting the psychiatric pluralism in India. I think that's the way our health system works. Thank you so much. With this, I would like to thank all three of you for such wonderful, stimulating sessions to start off the conference. Thank you so much. And it's really a pleasure to have you all three. And thank you.
Thank you.
Thank you so much.